Pasok ko, umalis naman si Kuya.
Sige na.
Ate, sunod mo yung ano ko,
Ano?
yung charger.
Anong tingnan?
Sige.
Ikaw pala ang nandito. Last na subject na niya eh.
Okay. You may start.
Hi pa, Doc.
Okay, good afternoon. So for this afternoon, we will have universal healthcare along with what we see how Philhealth and DOH would be the implementing arm of this endeavor such as universal healthcare. Okay, go ahead.
So good morning, everyone. So today we will discuss about the universal healthcare. So according to the WHO, universal healthcare or coverage means that all people have access to health services they need when and where they need them without financial hardships. It includes the full range of essential health services from health promotion to prevention, treatment, rehabilitation, and palliative care. So the Republic Act number 1223 or the Universal Healthcare Act is an act instituting universal healthcare for all Filipinos, prescribing reforms in the healthcare system and appropriating funds. So on February 2019, President Rodrigo Duterte signed the Universal Healthcare Bill into law. So the salient features of the universal healthcare law are the expansion of population, service, and financial coverage through an array of health system amendments. So it also involves planning paradigm shift to primary care, which is the core and the center of all health reforms under the UHC. So it is said that with universal health care, all Filipinos are guaranteed equitable access to quality and affordable healthcare goods and services and protected against financial risk. So with the help of universal healthcare, it ensures every Filipino is healthy, protected from health hazards and risks, and has access to affordable, quality, and readily available health services that is suitable to their needs. So it involves your primary care focused health system. So here, the front line of health services will be strengthened so that every Filipino will have a trusted primary care provider. So what does primary care mean? So it refers to the initial contact, accessible, continuous, comprehensive, and coordinated care that is accessible at the time of need, including the range of services for all presenting conditions and the ability to coordinate referrals to other healthcare providers in the healthcare delivery system when necessary. So the primary care provider will be the initial and continuing point of contact of patients or clients with the health system. So if higher level services are needed, the primary care provider will navigate patients or clients to a healthcare provider that can give the appropriate care. So the Declaration of Principles and Policies of this Act, so it states that it is the policy of the state to protect and promote the right to health of all Filipinos and instill health consciousness among them. So towards the end, the state shall adopt an integrated and comprehensive approach to ensure that all Filipinos are health literate, provided with healthy living conditions, and protected from hazards and risks that could affect their health. Second, a healthcare model that provides all Filipinos access to a comprehensive set of quality and cost-effective, promotive, preventive, curative, rehabilitative, and palliative health services without causing financial hardship and prioritizes the needs of the population who cannot afford such services. Another is a framework that fosters a whole system, whole of government, and whole of society approach in the development, implementation, monitoring, and evaluation of health policies, programs, and plans, and a people-oriented approach to the delivery of health services that is centered on people's needs and well-being and cognizant of the differences in culture, values, and beliefs. So its general objectives includes to progressively realize universal healthcare through systemic approach and clear role delineation of stakeholders, and also to ensure equitable access to quality and affordable healthcare and protection against financial risk. So who will benefit from the universal healthcare? It is said that all Filipinos will benefit from the Universal Healthcare Act, and the government will ensure that the well-being and health needs of all Filipinos, especially those of the vulnerable population, will be addressed. As mentioned earlier, universal healthcare law involves the expansion of population service and financial coverage. So for the population coverage, there will be an automatic inclusion of every Filipino citizen to the National Health Insurance Program. And the membership into this program was simplified into two types, which is the direct contributors and the indirect contributors. Next is for the service coverage. There will be immediate eligibility and access to population and individual-based health services. So the individual-based health services refers to services that which can be accessed within a health facility or remotely that can definitely traced back to one recipient and has limited effect at the population level and does not alter the underlying cause of illness such as ambulatory and inpatient care, medicines, laboratory tests, and procedures. While the population-based health services refers to the interventions such as health promotion, disease surveillance, and vector control which have population groups as recipients. So another for the coverage is the financial coverage. So the law also addresses the fragmented and the overlapping roles and responsibilities of the various health agencies. So for instance, the Department of Health and the local government unit will be responsible for population-based interventions and health services. For example, immunization programs and health promotion programs, while the Philhealth will be responsible for financing individual-based health services. So will all health services, another common questions with regarding the universal healthcare is will all health services be free through a universal healthcare act? So it is said that some health services may become more affordable, but not everything will be free. And one goal of the UHC Act is to decrease the out-of-pocket expenses of the family. So at the very least, the prices of health goods and services will be predictable and affordable. And depending on the available budget, such as additional revenue from the tobacco, alcohol, and sugar-sweetened beverage taxes, and the value-based decision of health technology assessment, the DOH and Philhealth will design benefits for this.
So, what are some of the pros and cons of the universal healthcare law? So, basically, the advantage would be that all citizens are automatically entitled to the PhilHealth benefits, including the outpatient services. This makes it easier for patients to access healthcare services and seek treatment, especially for early childhood care, preventive, and palliative care. On the other hand, there would also be an increased demand for healthcare services. This would also result to the standardization of services and the development of a health information system. So basically, under the UHC, both the public and private hospitals and health insurances groups will be required to maintain a health information system that will contain all the information such as the electronic health records, the prescription logs, and human resource information that would be needed by the Department of Health and Philhealth. And also, this would be subject to the patient confidentiality rules and the data privacy laws. On the other hand, as previously mentioned, all the healthcare services are provided, pero they're not totally expense free. So there would be some minimum fees that would be paid by the members, and um, this would also result to less flexibility for health professionals in negotiating some rates because all the rates would be standardized. And while there is an increased demand for healthcare services, this could further diminish the quality of care that some people would receive. And there would also be longer processing or waiting times to avail benefit for some procedures. And what would be evident would be some healthy people would pay for others' medical care. So in our country kasi, the chronic diseases usually make up for around 90% of the healthcare cost. And the sickest would be 5% of the population, which create most or 50% of our total healthcare cost. While the healthiest, which are 50% of our population, only create 3% of the cost. Next slide, please. So we go to Philhealth, which is under your UHC. So Philhealth is under your National Health Insurance Program, which is a compulsory health insurance program of the government under the National Health Insurance Act of 1995, or RA 7875, which aims to provide health insurance coverage and ensure affordable, acceptable, available, and accessible healthcare services for all citizens of the Philippines. So for Philhealth, this is a tax-exempted government corporation which is attached to the Department of Health for policy coordination and guidance of your NHIP. So the vision of Philhealth is for bawat Pilipino, bawat miyembro, protektado, kalusugan ng lahat, sigurado, and the mission would be benepisyong pangkalusugan, sapat at dekalidad para sa lahat. The PhilHealth also revolves around 7 core values, which includes integridad, inobasyon, agarang serbisyo, taos-pusong paglilingkod, pagmamalasakit, angkop na benepisyo, pandipunang pagbubuklod. In summary, all Filipinos shall be mandatorily covered under the program as mentioned under your UHC law, and in accordance with the principles of the universality and compulsory coverage, implementation of the program shall ensure sustainability of coverage and continuous enhancement of quality of service. It's also compulsory in all provinces, cities, and municipalities nationwide, notwithstanding the existence of LGU-based health insurance programs. So the PhilHealth, along with the DOH, LGUs, and other agencies, such as your NGOs, your NGAs, shall ensure that members in such localities shall have access to quality and cost-effective healthcare services. So who are the members of PhilHealth? So it's divided according to your members of formal economy, members of your informal economy, and indigenous members and the lifetime members. So first we have the members of the formal economy. So those are with formal contracts and fixed terms of employment, including workers in the government and private sector, whose premium contribution payments are equally shared by the employee and the employer. So under the members of formal economy, we have your government employees. Next slide, please. Um, we have your private employees, which are members of corporations, foreign business organizations, foreign governments, or international organizations. We also have, next slide, please. All other workers rendering services, whether in government or private offices, such as job order contractors, project-based contractors, and the like, owners of enterprises, and owners of small, medium, and large enterprises. The members of formal economy also include your household helpers and your family drivers. For the next category would be members of your informal economy, and this sector would include the following, but are not limited to: migrant workers, such as those documented or undocumented Filipinos who are engaged in your remunerated activity in another country of which they are not citizens. The informal sectors, such as your pedicab drivers, tricycle drivers, your food on street hawkers, your market vendors, your construction workers, and home-based industry and services. Next slide, please. We also have self-earning individuals, or those who are self-employed, and this include doctors, lawyers, engineers, artists, architects, and the like. And we also have Filipinos with dual citizenship. Next slide, please. Naturalized Filipino citizens and citizens of other countries working and or residing in the Philippines, such as those foreign citizens with valid working permits, or aliens or certificate of registrations working and or residing in the Philippines. Next slide, please. So another category would be your indigenous people, or your indigents, which are those people who have no visible means of income, or whose income is insufficient for families' subsistence, as identified by the DSWD. Those sponsored members, or a member whose contribution is being paid by another individual, government agency, or private entity. Next slide, please. And we also have lifetime members, which includes your retirees or pensioners from the government sector. Next slide, please. Retirees or pensioners from the private sector. Next slide, please. Uniform members of the AFP, BNP, BJMP, and BFP. Next slide, please. And those members of Philhealth who have received or have reached the age of retirement as provided by law and have met the required premium contributions of at least 120 months, regardless of their employers or sponsors arrears in contribution, and is not included in the sponsored program, nor declared as dependent by their spouse or children. Next slide, please. So dependents are those who are legitimate spouse who are not a member of PhilHealth, those who are unmarried and unemployed, legitimated, acknowledged, and illegitimate children below 21 years of age, and those children who are 21 years old above who are suffering from congenital disability, either mental or physical, or any disability, and those parents who are 60 years old and above, not otherwise an enrolled member, whose monthly income is below an amount to be determined by the corporation. That's all. Thank you.
Next, for the benefit entitlements under PhilHealth, the objective of this is that the National Health Insurance Program aims to provide its member with a responsive benefit package. In view of this, the corporation shall continuously endeavor to improve its benefit package to meet the needs of the member. And for the activity, to achieve the above objective, the corporation shall undertake the following activities, such as introduce additional benefit items while improving those already being provided, develop the appropriate provider payment mechanism, and continuously improve system for benefit availments. Next. So for the benefit packages, first is for the inpatient hospital care. So under the inpatient hospital care, the PhilHealth provides room and board, services of healthcare professionals, diagnostic, laboratory, and other medical examination services, use of surgical and medical equipment and facilities, and prescription drugs and biologicals. So under the inpatient benefits, these benefits are paid to the accredited healthcare institute through all case rates such as A, B, C, D, and Z. The case rate amount shall be deducted by the healthcare institute from the member's total bill, which shall include professional fees of attending physician prior to discharge. The case rate amount is inclusive of hospital charges and professional fees of attending physician. Next. So for the document needed, a copy of member data record or PhilHealth benefit eligibility form and the duly accomplished PhilHealth claim form 1. And then this is available in all accredited health center institute, and only admissible cases shall be reimbursed. Next, so this table shows the following packages under the inpatient benefit. So under the medical,
EJ, sorry.
yes, doc.
Can you go back? Can you go back to the last slide? I just want some clarification.
Uh, yes po, doc.
Okay, okay. Sige, sige. Thank you. Sorry, sorry. Go ahead.
Okay na po, doc. Okay.
Yeah, okay na. Okay, okay.
So this table shows the uh, and inpatient benefits under the medical care and surgical cares. So next is the outpatient hospital care. So under the outpatient hospital care, it includes services of healthcare professionals, diagnostic, laboratory, and other medical services, use of surgical or medical equipment and facilities, personal preventive services, and prescription drug and biologicals. So under the outpatient benefit, first is day surgeries. So ambulatory or outpatient surgeries are services that include elective or non-emergency surgical procedures ranging from minor to major operations, where patients are safely sent home within the same day for a post-operative care. The payments for this procedure are made to the accredited facility through all care rates. The case rate amount shall be deducted by the healthcare institute from the member's total bill, which shall include professional fees of the attending physician prior to discharge. And then the case rate amount is inclusive of hospital charges and professional fees of the attending physician. Another is radiotherapy. The case rate for radiotherapy using cobalt is 2,000 per session and 3,000 per session for linear accelerator. It includes radiation treatment delivery using cobalt and linear accelerator. The claims for multiple session may be filed using one claim form for both inpatient and outpatient radiation therapy, and may be availed of even a second case rate or full case rate amount. So 45 days benefit limit. So one session is equivalent to 1 day deduction from the 45 allowance days per year. If the procedure is done during confinement, only the total number of confinement days shall be deducted and exempted from a single period of confinement rule. Another is hemodialysis. The case rate for hemodialysis is 2,600 pesos per person. It covers both inpatient and outpatient procedure, including emergency dialysis procedures for acute renal failure. The claims for multiple session may be filed using one claim form for both inpatient and outpatient radiation therapy. Uh, Typo po yung radiation therapy. It may be availed of even a second case rate, 90-day benefit limit. So one session is equivalent to 1 day deduction from the 90 allowable days per year. If procedure is done during confinement, only total number of confinement shall be deducted, and also the procedure is exempted from the SPC rule. And another outpatient is outpatient blood transfusion. The case rate of outpatient blood transfusion is 3,640, one or more units, it includes drugs and medicine, X-ray, lab, and others, operating room. It covers outpatient blood transfusion only. 1 day transfusion of any blood or blood product, regardless of the number of bags, is equivalent to one session. May be availed to of a second case rate or full case rate amount, and a 45-day benefit limit. So one session is equivalent to 1 day deduction from the 45 allowable days per year, and also exempted from the SPC rule. So another benefit packages are health education packages, emergency and transfer services, and such other healthcare services that corporation determines to be appropriate and cost effective. So there's another benefit package, the so-called Case Z packages, which includes rare diseases, but hindi ko na po in-include dito because there are a lots of rare diseases to be discussed. So the benefit package for confinement of members and their dependents shall not exceed the benefit package provided by the corporation. For the exclusion of these benefits, the expenses for the following services shall not be covered by the NHIP except when corporation, after actuarial studies, recommend their inclusion subjects to approval of the board, such as fifth and subsequent normal obstetrical deliveries, non-prescription drugs and devices, alcohol abuse or dependency treatment, cosmetic surgery, optometric services, cost-effective procedure as defined by the corporation. So provided that such actuarial studies must be done within a period of three years and then periodically reviewed to determine the financial sustainability of including the foregoing personal health services in benefit package provided under Section 10 of the NHI Act as amended. For the entitlement to benefit, at least 3 months, a member of whose premium contribution for at least 3 months have been paid within 6 months prior to the first day of his or her dependent's availment shall be entitled to the benefits of the program, provided that such member can show that he contributed thereto with sufficient regularity as evidence in their health insurance ID card, and provided further that he is not currently subject to legal penalties as provided for the Section 44 of the RA 7875. Next. So the following need not to pay a monthly contribution to be entitled to the program's benefits. Retirees and pensioners of the SSS and GSIS prior to the effectivity of the NHI Act of 1995, members who reach age of retirement as provided by the law and have paid at least 120 monthly contributions and enrolled in digents. And then for the requirement for availment of benefits, to avail of NHIP benefits, a member must present the PhilHealth identification card or certificate or any other proof of membership and contribution. So the members and or their dependents shall be eligible to avail of benefits of confinements outside the country, provided that the conditions for entitlement under this rule are met and the following requirements are submitted within 180 days, 180 calendar days from the date of discharge. These are the official receipt of any proof of payment and statement of account from the PhilHealth Institute where the member or dependent was confined, and certification of the attending physician as the final diagnosis, period of confinement, and services rendered. The benefits to be granted shall be paid in the equivalent local rate based on the tertiary hospital category of the applicable case payable payment rate and the specialist rate for professional fee. And then the benefits of survivors of deceased SSS pensioners, qualified dependents of deceased SSS members, and who consequently became SSS survivorship pensioners prior to the effectivity of the Act on March 4, 1995, shall continue to be entitled to the benefits of NHIP. Next, this is a program under the PhilHealth for the indigent people called the PhilHealth's Indigent Program or ProPoor program. So for the summary, Uh, Next, the objective of this program, the general objective is this joint DOH PhilHealth order aims to set the governing policies and guidelines in the enrollment of critical poor to PhilHealth in government hospitals and their immediate availment of personal health benefits. So for the specific objective, it is to describe the rules and procedures in the enrollment of critical poor admitted in government hospitals and to state the benefit and of these critical poor members. For the identification of indigent members, under Section 22 of RA 7875, PhilHealth shall initiate the signing of a memorandum of order of agreement with LGUs and with other concerned parties for the implementation of the indigent program in their areas. So indigent as identified by RA 7875 are person who has no visible means of income or whose income is insufficient for subsistence of his family as identified by DSWD. And these are the poor is often considered synonymous with indigent household. Identification shall be undertaken through a social research survey referred to as the means test to determine current socioeconomic and health profile of the indigent sector in each LGU. For the enrollment of indigent members, community-based information system, minimum basic needs, or CBIS MBN approach. It administered at the barangay level by the city or municipal social welfare and development office and or the barangay shall be interfaced with the means test protocol, and LGU and PhilHealth shall give priority to the enrollment of the elderly, disabled, orphans, and paupers. Enrollment shall include the identification of beneficiaries, issuance of appropriate documentation, specifying eligibility to benefit, and indicating how membership was obtained or is being maintained. And once enrolled, the list of indigent members shall be evaluated every year, and membership can be revoked or canceled for any of the following reasons, such as non-compliance by the indigent member and employment of the member resulting to change in membership status or an increase in family income above poverty threshold. And in case of death of the member, dependents shall continue to avail the benefits of the unexpired portion of the coverage. So LGU or premium donor may extend membership beyond the unexpired portion of the orphans of deceased members. For the uniform basic package for indigents, an indigent member is privileged to enjoy following minimum services which are subject to limitations specified in the Act. So in inpatient hospital care, which includes room and board, services and healthcare professionals, diagnostic, laboratory and other medical examination services, use of surgical and medical equipments and facilities, prescription drugs and biologicals subject to limitations stated in Section 37 of the Act, and inpatient education packages. For the outpatient care, services of healthcare professional, diagnostic laboratory and other medical examination services, personal preventive services, and prescription drug and biological subjects to limitations in Section 37 of the Act. And another is emergency and transfer services and such other healthcare services that corporation and the DOH shall determine to be appropriate and cost-effective. So these packages shall be reviewed annually to determine financial sustainability and relevance. And the indigent program is being implemented in two phases. So for the first phase one, or the curative care, regular inpatient and outpatient package. So through PhilHealth accredited hospital providers entitles the members with coverage of the following services when hospitalized at accredited hospitals, such as room and board, services of healthcare professionals, laboratory and other medical examination services, prescription drugs and biologicals, surgeons, anesthesiologists, and operating room fees, surgical family planning procedures, outpatient benefits for chemotherapy, radiotherapy, hemodialysis, cataract extraction, and minor surgical procedures performed in an operating room complex. And for the phase 2 or preventive care, outpatient consultation and diagnostic package. So through Philhealth accredited, LGU managed rural health unit or health centers, entitled members with the following services from accredited rural health units and health centers, such as primary consultations, laboratory examinations for CBC, X-ray, stool exam, urinalysis, and sputum microscopy for suspected TB cases. And for the premium sharing scheme, under RA 7875, Section 29, or payment for indigent contribution, contribution for indigent members shall be subsidized partially by the LGU where the members resides. PhilHealth shall provide counterpart financing equal to the LGU subsidy for the indigents. In case of 4th, 5th, and 6th class LGU, the national government shall provide 90% of the subsidy for the period not exceeding 5 years, and the share of LGUs shall be gradually increased until such time that the share of LGU would be equal to the share of national government. And under R8 606, the amendment for RA 7875, it states that all premium contributions of indigent members shall be fully subsidized by the national government. That's all lang po.
Okay, thank you. Just a reminder, no, at your level as clerks and interns, when you present, no, uh, you should be more used to presenting now, and it's not just about reading what's on the screen. No, this goes out for all of us, because even your faculty would be guilty of this as well. No? But remember, the purpose of having a visual aid, like a presentation like this, is so that your audience has something to look at while you're talking. They should be, what we should be doing is scanning through your slide, and it's supposed to reinforce what you are saying to your audience. So if you are saying the same thing that the audience is reading, then we could might as well just send this out for everyone to read. Okay, can we go back to the very first slide in the first topic? Good morning, everybody. I skipped my mind to activate Zoom pala. Right. Let me go back to the very first. Okay, so the question here is there a drastic change that universal healthcare? Because you have to be familiar first with what is our healthcare system now, which what we discussed before, diba? Primary healthcare. Um, this is how it's being implemented, and then here comes your universal healthcare. Now, if you remember, what does universal healthcare actually mean? Uh, uh, it's different from uh, health for all, right? It's different from health for all. Kaya health for all is kalusugang pangkalahatan. Okay? Uh, universal healthcare basically has the same, but in principle would be similar. Okay? But from what we learned before, this has to encompass far more than just uh, healthcare. So if you think of it, universal healthcare, which is has a broader scope, universal healthcare or primary healthcare. What do you think?
Universal healthcare po, Doc.
Universal healthcare. So now let's look at what universal healthcare is. So our classic healthcare delivery service means, diba? Remember when we talked about the Astana Declaration and the changes that or the update that it made to primary healthcare, particularly including financing, no? Financing, what else? Your health human health resource, no? Human resource for health. I think that's a more appropriate term. So now let's look at universal health care and find if these are addressed. Even what else were added? Technical packages, no? If this was addressed, if this is being addressed in universal healthcare. Now, why do we want you? Why did we ask you to report on this, or why are we discussing this? Because this is now in effect. Universal healthcare started last September. Okay, it is now in effect. However, syempre, full implementation, as we would, uh, uh, realize, okay, usually full implementation takes around 2 to 3 years before this is fully implemented. Ang mabilis lang naman mag-implement dyan, BIR. BIR, pag nag-implement, bukas implement, okay. Outright implement na agad sila. Tax, tomorrow, tax agad. Are you aware of the new LTO vehicle registration policy? For those who own cars, no, when you renew the registration of your vehicle, you have to undergo the vehicular inspection, something VMIS, or motor vehicle inspection service, and VIS yata, no. And uh, what the view on this motor vehicle inspection service, it's not just about bringing your documents to LTO, have it renewed. Your vehicle has to be inspected by an accredited company. May checklist sila, and if you don't pass, you won't get to renew your vehicle. So therefore, you don't have a car anymore to use. It will cost you 1,800 pesos to apply for the registration. Um, if you fail, you only have 5 days to bring back your vehicle with the necessary, uh, uh, you know, changes for you to pass. No? Otherwise, you forfeit your 1,800. And yung feedback doon, based on those who've seen the checklist for this vehicle inspection, even if your car is 3 years old, it probably won't pass the inspection process. So just imagine that. And that's in effect today. That's in effect today. Right? So how it's going to be implemented, we don't know. As we said, most of what government would have, except for taxes, usually will take 2 to 3 years before this is really rolled out. So we're in the process of what we call the transition period for this. Okay? And what are the changes that universal healthcare did? Sinong author ng universal healthcare law? You should know this kasi Duterte says this over and over again every time. Yung laging kaakibat yung implementation of universal healthcare by Senator ganun. Sino? Every time he mentions universal healthcare, the senator has to be mentioned together with it. Okay?
Senator Ralph Rec.
No.
No, sorry.
No. Si Go. So may inkling na kayo sinong tatakbo sa 2022. That's why they had when the signing of the universal healthcare came out, nagulat ang medical community. Kasi what most were saying, there wasn't enough consultation done on universal healthcare. No? Pero ang sasabi ng government, I'm not too privy on whether there were enough consultations on this law. Was that it was implemented during the pandemic. It was signed during the pandemic. Okay, so para sabi nila, oy, nakalusot. Okay, but let's look at the universal health care. Now, with everything that new, oftentimes there would be hesitance, no? Just like the vaccine right now, and resistance, no, to change. Okay, but let's look at it. So basically, what's the essence of universal healthcare? It's from the word to provide healthcare services to everyone. Okay, to everyone, but not just everyone, to provide appropriate and timely health care to everybody. That's why they came up with this scheme. Now, mind you, universal health care is not a unique program to the Philippines. This is actually mandated by the World Health Organization. So there are other countries which have already started universal healthcare. Whether it's implemented the same way here in the Philippines, we've yet to see, no, and analyze. So if you're interested, you look at India in our discussions with international students. They have universal healthcare already. I think it's more than 5 years already. But 5 years later, if you watch White Tiger, on Netflix, you get to realize, has there been an improvement in their healthcare? Okay. So let's move on. So basically, this is an upgraded primary healthcare. No, so on February 2019, signed the Universal Healthcare Bill into law. So this was after after the Taal volcano eruption. While the country is in chaos, of course, these things don't stop just of natural disasters and all of that. Okay. Okay. So what are the salient features? Okay, expansion of the population, service, and financial coverage. Okay. So as you mentioned, there involves planned paradigm shift to primary care. Now this is different from primary health care. Now, what's the difference between primary care and primary health care? Primary health care, that's the one that is we deem synonymous with public health, right? This is population-based healthcare. Okay, these are strategies to address communities, not only individuals. In primary care, which is the focus of primary care, it's basically individuals pa rin, although there are strategies for population-based interventions. But basically, it's still a person seeking consult and addressing the need of the person. Unlike primary health care, we don't only concern ourselves with the needs of that particular patient who is consulting, we are concerned with every aspect that affects their health. Diba? Kaya we also talk about social determinants of health, environment, and all of that. Okay? O sige, let's go. So primary care, in essence, what's your idea of primary care? That this would be where primary care and primary healthcare would seem to be similar. Because in primary care, we're concerned primarily with, do you have it there? Can you move on?
Doc, ano po,
Hmm.
the definition is, it refers to the initial contact daw po, and accessible,
Mhm.
continuous, and comprehensive coordinated care.
Ayan. So that is primary care. Meaning, um, at usually kasi what we have is tertiary care. Tertiary care meaning kung kailan may sakit na yung pasyente, that's when we address the illness. The essence with primary care is that people, since healthcare services are available, no, kaya dapat ganun nga yung primary healthcare. That's the essence of primary healthcare. Make services available. So since services are available, people would would readily consult for whatever health concern early on. 'Di ba? Early on. Primary care, early on. And then when they consult you, the essence of the universal healthcare law and the way it changed our healthcare delivery system is when they consult you, the care extends all the way until everything is resolved. Unlike what we have now, when you consult with your doctor, what do you do? Consult. Okay, interview, history PE, prescribe your drugs, do this laboratory, bahala ka na kung saan ka magpapalab. Bahala ka nang bumili ng gamot. That's our healthcare delivery system right now, right? Oh, it's up to you. Doc, hindi ko kaya to. Sige, nasa sayo na yon if you can do it or not. That's what an universal healthcare will try to address. You receive the care, you receive the health care at the appropriate time and the appropriate care. 'Di ba? Kasi if you need this to be done, and that is what's needed, that's why at this point in time it's very important for you to read on treatment guidelines, because that will be the standard of care that we have. So if you're talking about pneumonia and this is supposed to be done, you have to do your x-ray, you have to do culture and all of that. then that is the appropriate care at that appropriate time. Okay? And hopefully that is what universal healthcare will address. And how will universal healthcare address this? Okay, can you move on with your um, screen? Now the reason why Dr. Andres may butt in any time. No? The reason why I'm discussing this with you is because I've been through several discussions regarding universal health care. We actually sponsored a webinar on universal health care. Um, I've been talking to the hospital kasi they need to be aware of this. Why? Okay? So, front line of health services will be strengthened. Hindi yung kung may sakit ka na, emergency room, consult, of confine ICU. It's the front line. And what is the front line in primary health care? The health center, the barangay health station, our public health workers. In this case, we're not only involving public health workers, we're also involving uh, private healthcare providers. Okay? So, meaning, if you have a concern, consult already with someone who will provide you primary care. In the States, that's how they do it. Kaya malakas ang HMO sa States. No? Yung mga health maintenance organizations, because you cannot go through the health system without health insurance. And that's the drawback there. Pag wala kang health insurance, wala kang support. The idea is out of pocket lahat. In sa atin, majority of us is out of pocket. Okay, so how about those who cannot afford? Me personally, like I just had my laboratory tests done, blood tests, and it costs a total of 8,000 pesos. It's a good thing I brought money, and I was with my mother because my mother was the one who's supposed to get the tests done. So dalawa kami, 16,000 pesos. One visit to the laboratory. I had her 2D echo done. The 2D echo, the 2D echo cost 3,000 something with Doppler. Of course, she has discounts, and since we had it done in where a hospital where I'm affiliated, we receive discounts as well. Just imagine that, no? Even with the discount, I was so surprised with the cost. So my 8,000 went down to 5,000, 5,000, 6,000. The 2D echo from 3,000 went down to 2,000 plus. Okay, or three to some right. How about other people? How about our poor countrymen? Okay, but so far so good. No, so far so good. This seems to be encouraging. Kasi nga, what we want is for everybody to be able to seek consult at that time that they have to. Hindi yung kung kailan it's too late to manage their condition. But if you're gonna think of it, that's why we have health centers. That's why we have barangay health stations. So what would be the difference now? So again, the difference is we are now engaging private clinics as well, but these clinics have to be accredited, okay, in what we call a healthcare network. Ito, if higher level healthcare services are needed, the primary care provider will navigate, and that is the purpose of your primary care provider. That's why we identify them as primary care provider. Whether you are in the public health sector or you are a private practitioner, if you are an accredited primary care provider, this is the idea. Can you move forward? Okay. So integrated whole of system, whole of government, whole of society approach. So involving everyone, no? Comprehensive health services without causing financial hardship. And that is where Philhealth would come in. Of course, that's not to say that you cannot use your HMO, your other health insurances. Kasi the way Philhealth works, minus muna lahat ng HMO before Philhealth. So mas mababang percentage na yun. Mas mababa. But Philhealth, nowadays, hindi naman by percentage ang kanilang coverage. There's a standard amount already for a particular condition. Okay? Back when we were students, the way field health was handled is that you get a percent discount for a particular condition or a particular procedure that you undergo by percentage. So meaning, if the procedure costs 1,000 pesos, and the discount and the PhilHealth coverage is, let's say, 10%, and therefore you get 100 pesos off, right? But there was a contention there, particularly by one of our mentors, Dr. Rodriguez, Romualdez, no, Alberto Romualdez. He gave a special lecture to us about PhilHealth back when we were students. And his contention was, that's the wrong way to implement it. Why? Kasi his story, no, he's with the government hospital. Sabi niya, my patient who had a procedure, ENT procedure done in a government hospital, the cost of the procedure is 5,000 pesos. Okay. Let's say the coverage is 10%. How much is 10% of 5,000 pesos? 500 pesos, right?
500 po.
So therefore, the patient, the poor patient, that's kaya nga sa government hospital nagpunta, the poor patient now has to pay 4,500 kasi ang discount niya 500. And then he said, what about my niece? My niece underwent the same procedure in Medical City, which costs 50,000 pesos. How much would now be the discount? 5,000 pesos. That's conservative, 5,000, because discounts can go all the way up to 30,000 per 30% or 40%. A rich person consulting at the hospital gets a discount of 5,000 pesos for the same procedure, while a poor person in a government hospital gets 500 pesos discount for the same procedure. Sabi niya, fair ba yun? For the same procedure. For a for a rich person, 5,000 pesos might not be big, no? 5,000 lang. But for a poor person, 500 pesos is more than his livelihood for a day. No? So that was the main contention up until PhilHealth came up with the case rate. So ang case rate is, if you get admitted for a particular condition, let's say 3,000 pneumonia, ang case rate ng pneumonia is 3,000 pesos. Kahit saan ka ma-admit, you'll still get a discount of 3,000 pesos. So if you get admitted to a government hospital and your total bill is worth 3,500, then you only pay 500 pesos. If your bill is lower than the coverage, then you don't pay anything. If you get admitted to a private hospital wherein a single day admission for pneumonia usually takes around 3 to 4 days, it would cost you around, let's say, with antibiotics, around 40,000 pesos. And that will means you'll be discounted 3,000 pesos. Fair, kasi pareho lang yung na-discount. Pareho lang yun. Now, that brings us now to equality and equity. Diba? What's the difference between equality and equity? What they did with the case rates, that is equality. Kasi equal lang kayo ng benefit, both 3,000 pesos. The previous one was equity or equitable. No, the people who are able to pay more get more discount. The people are able to pay less get less discount. Kasi nga it equates with what your capability. Okay, so which is which? Which one do we want? WHO would say we would want more equitable than equal. No, equitable than equal. Kasi equal, sayang, dapat you have to get more for what you give more. Then that, nandun lagi yung, that's always the bone of contention. Okay? So, people-oriented approach. Kami, let's move on. So, why are we discussing this? Because who will be the primary care provider? You, when you become licensed. You're gonna be the primary care provider. But you have to undergo training. That's what our society is doing right now. No, I belong to the Philippine Society of General Internal Medicine. We actually have a training module for primary care for this. No, I was supposed to deliver a lecture, one of the lectures, pero I wasn't part of the lecturers before. So sabi ko, aralin ko muna kung anong lecture yan. If it's something to do with public health, kaya ko yan. But if it's something else rather technical, let's see. Okay, but we actually have an online for those the interns, hindi pa kayo makaka-access kasi you need to be licensed already. DOH already provided online training for primary care. online training. I'll get the link. I'll share the link so yung makita. Online training. Of course, there's orientation on what is universal healthcare, what is primary care, and all of that. Online training. I haven't finished my online training as well. Okay? So, DOH will now accredit private institutions. Now, if you get accredited as a primary care provider, what will happen? You will be included in what we call a health referral network. Can you move on? And let's see if you
Doc, may
mentioned.
question lang po ako.
Hmm.
Doc, yung mga specialist na doctor na po, hindi na po
Hmm.
sila pwedeng maging
Yan.
primary care provider.
That's a good question. That's one question that was posted every time we have a discussion on universal healthcare. The universal healthcare law doesn't anong tawag doon, discriminate whether you're a general practitioner or you're a specialist. But being in primary care, that means you, parang sa health center, you should be willing to look at every patient under your care. So, if you are a specialist and you say, ay, cardiologist ako, so cardiac lang ang titignan ko, not acceptable. Because that's not primary care. Diba? In essence, that's not primary care. Because especially in universal healthcare, you're supposed to address the need of the patient at that particular time. Ay, hindi ho cardiac yan. Balik na lang ho kayo pag nandito na yung general practitioner namin. That's not the case. No? Kaya ang question din nun, paano yung mga surgical? Now you have to go back to your general medicine roots. That's why in your curriculum, what's the first outcome there of medical school? To be a general practitioner. Whether you go into specialty practice, that's an alternative pathway or alternative career. But your training is actually designed for you to be a general practitioner. Diba? Kaya nga we always remind other faculty when they discuss, for example, in medicine, and they ask questions about pulmonology, let's say this and that. Sobrang hirap pang fellow na yan, pang specialist question na yan, and we try to discourage them from giving such questions. Kasi those items you're not supposed to you're not supposed to be handling those concerns, yung mga pang specialist level, at your level as general practitioner. Okay? So, who are your primary care providers? Ang pinaka, in essence doon, as long as you are trained and willing to look at all patients under your care. Kaya you have to undergo training. And then you will belong to a health referral network.
Hello?
Any questions for that? Yes. Ay, sino po?
Uh,
Si Doktora
on
ba
the
yun? Sige, Doktora.
contrary, on the contrary, there's also a perceived notion that if you're a specialist, you cannot look at these primary care concerns. And that is what happens to someone like me who
Mm-mm.
uh, is an OBGYN by specialty but would have public health advocacies that I am willing to look at um, male or pediatric patients at a clinic setting.
Mm-mm.
Sasabihin, ay, tinitignan nyo din po pala yan. So, you
Mm-mm.
will really have to explain again. Bago po ako naging specialista, I am a general practitioner.
Mm-mm.
Uh,
We should
and you
never
have,
forget our
and
GP roots.
yes, and the public should also be always you just explain to your patient that it's like that. Nagugulat
Pero
talaga sila.
yeah, like ako, I came from public health as well. So in my stint in public health, I look at all patients. Now, but that's the problem. Kasi like for us in our healthcare system, doctor-centric or hospital-centric ang ating healthcare system. Kaya nga patok yung mga high precision. 'Di ba? Kaya patok yung mga high precision kasi you're not confined to the restrictions of a hospital. Why? Kasi pag nasa hospital ka, if you're an IM, ang rule, you only look at patients 18 and above. Pag pediatrician ka, ang titignan mo, below 18 years old. If you cross that line, issue yun sa hospital. Kasi the pediatricians would say, bakit mo tinitignan yan? Pasyente ko yan. Di ba? Right? If the IM looks at, like in one instance, this is a shareholder of the hospital, 17 years old, sa akin nagpa-schedule. So I had to look at the patient kasi shareholders, siguro wala namang magrereklamo ibang doktor, shareholder, may-ari, ano, kasama sa may-ari ng ospital eh. But I reminded them that on follow-up, they have to be seen by a pediatrician kasi pediatric age pa yung pasyente. Okay? That's the problem with hospitals. That's why not everyone will be a primary care provider. Sabihin ko, primary care provider ako ha, pero hospital-based ako. Kasi yung question dyan, kung primary care provider ba, it should be outside the hospital? No. It doesn't necessarily have to be outside the hospital. But the problem is the restrictions with the policies of tertiary hospitals particularly, wherein they delineate which kinds of patients can be seen by which doctor. Diba? So that's a problem. So in my case, yung clinic ko that my sister already opened, yung medical clinic, yung dental clinic na open yan, yung medical clinic, I'm still setting it up para maging primary care. Kasi when, let's say, you have to undergo training and have to have accreditation. Kasi if you're accredited, then there's no question. Your colleagues cannot question you, bakit tinitignan mo yung ano? Now, the only person, that's why the Society of Family Medicine are saying they are at the forefront of primary care and universal health care. Why? Because they look at all patients of all ages. Diba? They're essentially in, let's say, in private practice, they're essentially the general practitioners of the specialists, no? Because they practice general medicine. But that's not to say na automatic primary care provider na lahat ng family medicine. They still have to undergo orientation and training and accreditation. Okay? So, it's more of a technicality with the institution that you are included in. No, lalo na when you go into training. And during my training, nagkakaroon ng issue, no? Kasi pagdadating yung pasyente, ang doktor pediatrician, nag-birthday na. 18 years old na. Oh. So, ang gagawin ng pediatrician, sa IM na yan. There are some pediatricians who are very, talagang caring na they would extend their care up until they endorse it properly to an internist. Pero yung iba, 18 na yan, hindi na yan, kahit gustong kunin ng pediatrician, hindi na pwede kasi 18 years old na yan. Sa IM na yan, reject na natin sa IM. Wala namang alam yung IM tungkol doon sa kaso. Right? So, nawawala yung continuity of care. And that's what primary care will avoid. Kasi one doctor will oversee the healthcare of the patient all throughout the healthcare process. From the start of the consult until matapos yung problema niya. So, for example, I'm a primary care provider and this is, sige, can we move on kasi I want to see if I came in late. I want to see if you mentioned there the healthcare referral network. Okay? O sige, next. Move on. Okay, who will benefit? All Filipinos. And that's the weird thing kasi technically, all Filipinos are Philhealth members already. Even if you don't have a membership, pag when you consult, pa-process agad ng Philhealth. They already did it with the senior citizens. Automatic yun, Philhealth member ka na, and you're automatically eligible for the benefits of Philhealth. Of course, you have to submit stuff and all of that. Okay? So, all Filipinos, hindi na yung kung sino lang yung nag-apply, sino lang yung may Philhealth card, all Filipinos under universal. But we haven't seen that yet. I've had patients admitted after yung supposed implementation, start of implementation of universal healthcare, hindi pa rin nakaka-avail ng, even senior citizen, hindi pa rin maka-avail automatically of the Philhealth benefits. So, this is what we're saying. No? Even if they're saying it's effective now, that's more of for para lang sa accomplishment report. Pero in terms of actual practice, it would take several years before this is actually in full swing. No? Sige, let's go ahead. Let's move.
Hindi po namin na-include yung referral.
Oh, sige. So what's that referral network? And I already mentioned this to Dr. Crisostomo in one of our meetings. Ma'am, is the hospital applying as an Apex hospital? Kasi what's gonna happen in universal healthcare? I'm a primary care provider. These patients will have to be registered under me. So, for example, nasa Las Piñas ako. Ang pasyente, Traditionally, ang doktor niya nasa Manila Doctors. Right? Okay. Saan ka magre-register ngayon for your primary care service under UHC? Okay? Pag nag-register ka sa Manila Doctor, doctor mo sa Manila Doctor, kung primary health provider yon, pag may concern ka, sa kanya ka lang pwede pumunta. Kasi under ka ng referral network. So the idea here is, if you're a doctor in a certain locality, ideally, yung mga patients mo are the people in the locality. Kasi if they have a concern, you're readily accessible. Okay? There is a registration process. Pipili yung pasyente kaninong doktor siya ma-under, kaninong primary care provider siya ma-under. Okay? Kasi why? What we want here is continuity of care and familiarity of the doctor with the condition of the patient para ma-manage niya properly. And the keyword there is man-navigate niya properly. So, patient registers under me and I am registered under a referral network. For example, I have a clinic. I'm under the referral network where the top of the referral network is the Apex Hospital. The Apex Hospital supposedly is a tertiary hospital. And what tertiary hospital are we familiar with? Perpetual. That's why I'm asking Dr. Crisostomo to bring it up. Are you applying as an Apex Hospital under Universal Healthcare? Bakit? When a patient consults with me and sabihin ko, okay, alright, sige, we'll work you up, ito pagagawa mo. Kanino ko i-refer yung pasyente pag nagpa-laboratory? Siyempre, dun sa member ng referral network. And if the laboratory is the Perpetual Laboratory, o punta ho kayo sa Perpetual, doon ho kayo magpapalaboratory. Doc, covered ba yan ng PhilHealth? Under Universal Healthcare, dapat covered na siya ng PhilHealth. So there will be services na free kung doon ka pupunta sa referral facility within your network. Nagets nyo? Pag nagpagawa ka sa labas, outside of your network, malamang hindi i-cover ng PhilHealth yan. Kasi this is another way of monitoring the patients and the facilities. Okay? So, libre. Bakit kailangan dun mismo sa hospital na yon? Kasi at the point of consult of the patient, the doctor won't get paid. Kasi yung consult covered din ng PhilHealth. That's why it should be universally accessible under the scheme. Gets nyo? Hindi ka na mag-iisip, wala akong pambayad. No, because PhilHealth will cover your consultation fee. Pag nagpa-laboratory ka, PhilHealth is supposed to cover the laboratory expenses. Okay, pag napa-confine, saan ka i-confine? Doon din sa hospital within the referral network. So the hospital now can readily manage kasi alam niya kung gaano kalaki ang kanyang patient base. Right? Doon sa referral network. Okay? So all under a Apex Hospital. Like let's say, Perpetual nag-apply. So under ako ng Perpetual. Why?
Doc,
Kasi, yes, DJ.
question po. If primary healthcare ka po, tapos i-refer mo sa Apex Hospital, kailangan po ba doon ka sa affiliated mong hospital or kahit sa ang Apex Hospital po?
No, it has to be within your own referral network. Hindi ako, kung ang Apex Hospital ng referral network ko is Perpetual, I cannot refer the patient to Asian. Kasi hindi siya ang Apex Hospital ko under the primary care scheme of Universal Healthcare. Kaya nga, ang decision dyan is nasa pasyente. Saan ka magre-register? Saan ka gusto ko sa Manila Doctors ako ma-confine, mag-register ka sa primary care provider mo sa Manila Doctors.
So, Doc, ang isang primary healthcare, isang Apex Hospital lang siya pwede?
Ideally, that should be the case. Okay? Kasi tinanong din namin yan, paano kung marami akong clinic? Siyempre, iba-iba rin yung primary. Kasi ang i-register sa'yo is not only you, your facility. So, halimbawa, marami akong clinic. May clinic ako sa Bacoor, may clinic ako sa Las Piñas. When I'm in Las Piñas and the patient is registered under me in my Las Piñas clinic, I can only refer to my Las Piñas Apex facility or Las Piñas Referral Network. Hindi ko siya ipapakross ng Bacoor. Ganun yun. Kaya the decision here lies on the patient. And that's the one thing the patient should understand. Eh, hindi pa, wala pang nag-explain sa mga pasyente. Kasi nga, wala pang ang registration na nangyayari. Right? And remember, this is not only for private institutions, also for your health centers. And sa health center, remember, established ang referral network ng health center. Right? We already studied that. Establish ang referral ng health center. Kaya nga mayroong referral network ang inyong public health facilities. And that's what they also want to happen sa universal healthcare, especially in the private sector. Kailangan meron kang referral network. Why? Why the importance of following the referral network? Kasi remember, all of these are covered by PhilHealth. It's the apex hospital who will receive the lump sum of the payment. So Perpetual is our apex hospital. Perpetual will be the one to give me my payment for the consultation. Doon ibabagsak ang payment. Yan, nagre-react si
Good luck
Dr.
sa
Andres.
doktor.
That's already being implemented now. But within the hospital. So meaning pag ganito ang sistema natin ngayon. When you admit a patient in the hospital, syempre covered sila ng PhilHealth. The amount will be deducted. Before, what happens is PhilHealth will send you a check. Tulad sa akin, I used to practice in Laguna, in Cabuyao. May question ako doon sa PhilHealth check ko. Kailangan ko pumunta ng Cabuyao to ask PhilHealth Cabuyao. Now, what happens now is the PhilHealth doesn't have any contact with the doctors anymore. What will happen is the hospital, kaya lahat ng payment dapat through the hospital. The hospital will report this deduction to PhilHealth, and PhilHealth will pay the hospital, and the hospital will now distribute the payment. Cheque ng hospital ang i-issue sa'yo. And you will issue now a receipt to the hospital, not PhilHealth. You can indicate there for PhilHealth, but yung hospital ang i-issuehan mo ng resibo. Because before, we had to issue a receipt to PhilHealth. Yon. So that's why they have to be strict with the health referral network. Kasi if you are a primary care provider and you refer to another hospital, another network, you don't necessarily get your payment. Kasi hindi ka kasama sa roster ng hospital. Pag nag-divide na ng bayad, wala ka sa master list nila. Paano kanya babayaran? Right? Wala kang bayad. That's why you have to stick to your referral network. And that's why Perpetual, for instance, Las Piñas Doctors Hospital, okay, Pope John Paul, for example, Las Piñas Medical, ano pa ba, yung mga Alabang Medical Center, all of that, they have to be familiar with this. Ang maghahalo ng pasyente dyan, LPDH at Perpetual, kasi magkalapit. No? So, that's their scheme on how they're gonna provide the health necessary kasi naka-plan out na. And that's why you are now called a navigator. Because you are the one who's supposed to know where your patient is supposed to go. So pag nagpa-laboratory yung pasyente, babalik sa'yo. Okay? Kailangan mo ng surgical consult. Diba? Refer kita sa surgeon, and the surgeon has to be a member of the network or the hospital itself. Kasi hospital-based. Refer kita sa surgeon. Ginamot. When the patient has already been treated, discharged, the patient has to come back to you kasi kailangan manote mo kung anong naging outcome nung consultation mo. So in the next instance that the patient has another concern, kanino siya pupunta? Let's say the patient has a surgical concern again. Again, the patient doesn't go to the surgeon. The patient goes back to you and you determine which surgeon you will refer the patient to. Kaya ito ang magiging problem for specialist, subspecialist, because it's the primary care provider who will determine kung i-refer sa'yo o hindi. The power of the primary care provider. So, halimbawa, may listahan ka ng 5 cardiologist. Ayoko dito sa cardiologist na to. Wala naman nakalagay kung anong basis for referral eh. Ayoko, masungit daw to. Sabi nung isang pasyente ko, hindi kita i-detect. Bigay kita dun sa cardiologist na yun. Walang naka-state how the referral will go about. It's up to the primary care provider. Kaya huwag kayong mga away ng primary care provider pag specialist kayo. Baka hindi kayo ma-referan. Although that's very unethical, pero wala namang nakadictate na kailangan meron kang susunding siko eh. Di ba? So far ha, walang nakalagay unless we see a revision to the I've already read the implementing rules and regulations kasi where every law there has to be an implementing rule. Nandun yung details ng program. Walang nakalagay na ganun. Okay? That's why the primary care provider will now have power over the health system. Okay? Kaya kung gusto niyo nang nag-iisip na kayo, ano bang career ko in pag nakapasa ako ng board exam, especially for our for interns, Ronuel, Monina, okay? Isip na kayo, magsa-subspecialty ba ako? If I go to subspecialty, gusto ko maging primary care provider. Remember, you don't need to be a GP per se. Di ba? You can be a specialist as long as you conform with the requirements of being a primary care provider. Sabi nga nung isa, pwede bang magka-team up kami? IM ako, pedya, cover na namin lahat, di ba? Akin yung mga adult, sa kanya yung mga bata. Eh, isa lang ang count nyo kasi isang consult lang yun. Di ba? Hindi mo pwede kayong bayaran pareho. Okay, but then that's something that they have to thrash out pa further. Kasi there were patients, kasi may requirement yun. Right now, the requirement is if you want to be a primary care provider, you should commit. No, you should commit to render service under the universal healthcare as a primary care provider at least 40 hours a week. So that's basically 5 days a week already of work. Basically, yun ang gagawin mo buong linggo. 5 days a week, 40 hours a week. So 8 hours per day, more or less.
Doc,
Yes, EJ.
Doc, paano po yung mga regular patient nyo po? Halimbawa, kayo po cardiologist po. Tapos, halimbawa, hindi po kayo primary health provider. Pero, yung mga regular patient nyo, kailangan pang dumaan sa primary health provider?
Yes.
Imbis na sa inyo po?
They cannot go directly to a specialist. They have to go through the primary care provider every time. Parang HMO on a wider scale, where the primary care provider is the coordinator. Kaya nga tawag sa inyo navigator. Kaya nga, napapaisip dyan yung mga specialist.
So for
Kaya
example,
napapaisip yung mga specialist. Yes, Doktora?
so for example, with me, I'm an OBGYN. Even if I have an existing patient, if they have to be seen first by a primary care physician and properly referred to me before I could see that patient.
Mm-hmm.
If
If
UHC would be fully implemented.
Mm-hmm. Now, the way to address that, again, is coordination. Kasi if I'm the primary care provider, and alam ko ang doktor niya is Doktora Andres, right? And okay naman ang feedback with Doktora Andres. Now, what's holding me back from referring the patient of, Doc, bakit po hindi ho ako niregla uli ngayong buwan na to? Okay, meron ka bang doktor? Si Doktora Andres po. Oh, part ng network. Sige. Ito na yung referral. Punta ka na kay Doktora Andres.
Sana ganun.
Sana ganun.
But what if the buck stops there?
Yes. Paano?
So
ang problem dyan, paano kung yung primary care, sige, ako na yan. Kaya ko na yan.
It's manageable. That the problem lies if it's purely medical. So, bale, ang marirefer na lang to your, for example, OBGYN would be the would be the ones that would need surgical interventions. Kunwari, papaanakin, CS, gynae procedures, etc. But anything medical, if your primary care physician is competent, and I would like to assume that sana most of them are, hindi na makakaabot yung referral sa'yo.
Actually,
because
that's the...
you'd get treated there.
Kasi remember, the essence of universal healthcare is timely, to receive healthcare at appropriate time, receive the appropriate healthcare at the appropriate time. That's the idea of your universal healthcare. Kaya nga, may training ang mga primary care providers in all fields. In all fields. Kaya ka nga i-accredit, meaning you are competent in all fields. So that's the concern now of, let's say, what Dr. Andres is saying. if I'm a very competent primary care provider, and it's not just for show, ha, talagang competent ako. Nag-aral ako ng med school, nag-focus talaga ako mag-aral ng internship. Pag-graduate ko, parang family medicine practitioner na ako sa galing ko. Wala nang aabot na pasyente sa mga specialist unless yung case is beyond your capability. So, ang iniisip, paano ngayon ang patient base ng mga specialist? Bababa. Kasi everyone else, other than the surgical, like for Dr. Andres who's in the surgical field, everyone else, for example, yung usually na, ano bang mga common surgical procedure na ire-refer mo sa surgeon? Kasi nasa clinic ka lang. Let's say, uvectomy. Appendicitis kasi kailangan mo ng hospital doon. Hindi ka naman pwedeng mag-surgery sa hospital kung hindi ka surgeon. Di ba? That's it. Di ba? Pero yung mga minor procedure na usually surgeon ang gagawa. So kung primary healthcare provider ka at capable ka mag-circumcise, lahat ng circumcision sa'yo na. Hindi mo na kailangan ng surgeon. Ikaw na lahat yan. Right? Yung mga excision, biopsy, ay hindi na kailangan. Primary care provider na gagawa niya, hindi na kailangan i-refer sa surgeon for excision biopsy. FNAB, tinrain tayo mag-fine needle aspirin. Hindi na natin kailangan mag-refer sa ENT. Tayo na gagawa niya. So just imagine the impact now on your specialists. Yun yung pinaka-concern ngayon, especially of those our colleagues who are specialists. But for you guys who are just starting your career, medyo it's a bright future. Mag-isip kayo if you're really going into residency or if you're going into further training. But then again, you can go into further training and become a primary care provider if you are willing to abide by the requirements of being a primary care provider. Okay? So mag-isip-isip. Kaya nga what lagi naming suspicion ngayon is ang board exam, maraming papasa dyan. Kasi one of my colleagues said, Paps, yung anak ng kaibigan ko, lats talaga. Hindi papasa ng board exam. Sumabit. Kasi ang alam nila kasi ang passing ng isang board exam, mababa. Na-delay yung pag-release ng result. Kailan yun? Kailan may na-delay yung release ng? Na-delay yung release ng result. Kasi yung isang nag-take ng board exam, kakilala ng board examiner. Nung lumabas yung board results, pasado. Parang siya yung naging benchmark para kung nasaan ang passing ng board exam. We would like to believe it's not the case. We would like to believe it's not the case. But the idea here, there should, ang inisip na dapat marami tayong GP. Kasi yun ang primarily mag-a-apply as primary care provider, yung mga general practitioner. Or yung mga family med. That's why actually, Dr. Andres, di ba, Dr. Crisostom has been asking Dr. Raymond Cruz, we really have to facilitate we really have to expedite the family medicine residency in perpetual. Kasi magbo-boom ang practice ng family medicine. And you don't even have to be in family medicine. Primary care provider as a GP, pwede. Okay? So ano bang plan nyo after ng board exam? Yes, Doktora.
The problem with the UHC as far as the OBGYN practice, of course, lying-ins would have midwives as well.
Yan.
So they're completely ignoring that fact. So they should accept that the lying-in and the midwives would also have to be part of that referral system. And they're not addressing that.
Kasi under our public our primary healthcare scheme, primary healthcare program, 'di ba? Ang midwives natin are basically general practice as well kasi they don't only look at gynecological obstetrical cases, 'di ba? But what about those in private practice? What about those in private practice? Yun ang isang kailangan nila address. Kasi pwedeng maging primary care provider ang midwife. Pero of course, may limit yung kanyang pwedeng i-address. Kaya ang focus more of this would be on the doctors. No? On the doctors. Kasi para ano kayo, all in one. All in one. Okay? So, question kung ako, doktor, may papaanak na pasyente, siyempre hindi ako magpapaanak kasi kailangan marunong magpaanak. Diba? Halimbawa, i-refer ko lang lahat sa midwife. Wawa naman yung OB. Kasi hindi naman kundi primary care provider. There are a lot of things they have to consider with this. But of course, the purpose is to provide health care and health financing. And remember last year, narinig niyo ba yung announcement? Nung pumutok yung magkano yung nawawala sa PhilHealth, 15 billion. 15 billion. That the reason why that issue came up was because of the implementation of universal health care. Narinig niyo yun, di ba? 15 billion nawawala sa PhilHealth. That's why it came up was because that was the start of that was, we think that was around August, no? July, August, because September was already the start of universal health care, and PhilHealth is the one financing universal health care. Kaya di ba nagkaroon ng appeal ang PhilHealth, i-postpone muna ang implementation ng universal health care dahil kulang ang pera. Kulang ang pera pero 15 billion ang nawala ninyo. Hindi nyo ma-explain.
Kulang ang pera pero ang bayad ng PhilHealth 90,000.
Diba?
Bawat doktor.
Oh, di ba? Hindi nyo ma-explain yung 15 billion pero kulang ang pera. Ay malamang kulang talaga yung pera. Okay. Okay, let's now go to the members. Kasi these are the things that you have to understand. Dalawang klase ng members, right? You were mentioning it. Dalawang klase ng members. Okay? You have your... Nasaan yung members nyo? Can you flash that? And by the way, para tuloy na tayo. 'Di ba vaccination fever ngayon, 'di ba? With regards to the vaccination. And maybe you've heard this, yung Health Technologies Assessment Committee, HTAC, Health Technologies Assessment. Okay? That was formed under Universal Healthcare. Yung Health Technologies Assessment Committee, they're supposed to look into all of these technologies like vaccines and all of that will be implemented kasi universal healthcare na tayo. So sila ngayon ang may hawak ng power whether to approve something or not. Then they will recommend to FDA for registration. For registration, yung HTAC. That's a very crucial component of your universal healthcare. So you will hear a lot about HTAC, especially when new technologies come up, kasi sila ang mag-evaluate, no, ng mga bagong technology, treatment, on all of that, okay, before it's approved by our regulating bodies. Okay, so who are PhilHealth members? Formal economy. So, sino yan? Yung mga nagtatrabaho. Whether kahit nasaan kayo. Okay, can you go to the next one? Kahit nasaan kayo, formal economy. Parang yan ba yung ano? Hindi. That is the PhilHealth. That's the PhilHealth definition before. Sige, can you go next? Next. Okay. Yan yung formal, yan yung definition ng PhilHealth. Okay, sige, next. Yeah, sige, go ahead. Nabanggit nyo kanina eh. Okay. Sige, go. Go ahead. Under universal healthcare, sige, tuloy lang kasi
Doc, nabanggit ko lang po siya sa ano. Wala po siya sa slides.
Ano yung binanggit mo kanina?
Ano po, dalawa na lang po siya, the direct and
Dalawa
the
na lang.
indirect contributors
Okay.
po, Doc.
Direct and indirect contributors. Yes,
Yes po.
dalawa. Direct and indirect contributors. Sino yung direct contributor? Yun na lang. Kasi remember, in a dichotomy, no one forget the other. Sino ang direct contributor? Lahat ng kumikita. Lahat ng kumikita. May trabaho. Professionals, employees, basta there's proof of income. They are direct contributors. And then the other side is yung hindi kayang mag-contribute, indirect contributors. So these are the ones who are sponsored by the LGU, sponsored by so and so, and more importantly, if you are a direct contributor, these are the ones that you are sponsoring. Kasi ang PhilHealth scheme is what we call a socialized financing. Those who pay for those who cannot. Nagets nyo? Those who pay for those who cannot. So yung mga indigent, since wala silang capacity magbayad, wala silang kailangang bayaran. But those who have to pay, have to pay. Kaya yung mga employed, babawasan na yung sweldo ninyo. Okay? That's why you're called direct contributors. Okay? Now, what's the drawback there? If you are an indigent and you are the indirect contributor, what's the consequence? Wala ka namang binayaran eh, di ba? Is it there? Wala ka namang binayaran. So, therefore, there's no problem. For a direct contributor, if you miss out on your payment, you still get the service. That's the nice thing. Kasi the problem with PhilHealth now, and Dr. Andres can attest to this, di ba? Pag hindi ka nakabayad, let's say, for the past 3 months, kasi may certain period, bawa, Doktora, pagka pregnancy ay for ano ba,
Iba
delivery,
sa, iba sa
ilang months?
pregnant. Sa pregnant kasi like it or not covered ng PhilHealth until 4 pregnancies.
Oo, pero
Pero
yung
kailangan,
payment nila,
technically dapat paid yung 9 months at least.
kailangan,
At the
kung
time
buka
of detection,
at time of detection ba, hindi yung at the time of
niya.
delivery.
Ah.
Oh, halimbawa,
Hindi, ma-update mo basta na-detect na.
oo. Kasi halimbawa, nanganak ka, hindi ka nakabayad ng PhilHealth mo for the past 9 months, hindi ka covered. Even if nagbayad ka for 10 years, if you missed out on your payment the 9 months prior to your delivery, hindi ka covered. I had a discussion with a PhilHealth manager with that one. Kasi nung before I went into government, wala akong PhilHealth. Ayoko ng PhilHealth. Kasi why? Unlike SSS where you get pension. Ang SSS kasi pag nagbayad ka, you get pension when you retire, you get benefits when you get sick and all of that. Ang PhilHealth, magbabayad ka. Pag hindi mo nagamit, forfeit na yung bayad mo. And may required sila, 3 months, 6 months. Kailangan bayad ka at least ng 3 months, 6 months, 9 months prior to you using your PhilHealth. So even if you paid for 10 months, then nakaligtaan mo magbayad ng 9 months. Then kinailangan mo yung PhilHealth,
Forfeit.
wala kang coverage. Forfeit mo na yan. Wala kang coverage. That's the problem. Kaya sabi ko, ayoko niyang PhilHealth. Pero empleyado na ako, so kailangan kong magbayad ng PhilHealth.
Dapat
That's the problem din.
Dapat sir may scheme, no? Pag hindi ka nagkasakit, meron kang reimbursable.
Dapat may dividends ka, di ba? Dividends sa tinatawag. Walang ganun ang PhilHealth.
For example ako, kahit malaki ang bayad ko sa PhilHealth as a healthcare provider, nagagamit ko siya kasi I get sick, na-hospital ako. So, hindi na rin masama sa loob ko kasi at a time, parang ang na-cover expenses nun minus 100K. So, parang nabawi ko din with my hospital expenses.
Pwede na.
But I got sick. So, paano yung, wag naman, yung ibang hindi nagkakasakit, wala na yun. That's down the drain.
Parang ako.
Nga,
Kaya ang importante doon, bayad, ang pinaka-focus nila doon, even if, let's say ngayon ka palang nag-start magbayad, 9 months, nagkasakit ka, covered ka na. Even if you haven't paid anything before, covered ka. Same coverage, ha? Same coverage. Kung 100,000 ang deduction mo, you get the same coverage as someone who has paid for 10 years. So, binago nila yan with universal healthcare. Pag hindi ka nakabayad, you still get the benefit. Yun ang maganda. Ha?
Huwag ka na magbayad.
Kasi considered kang PhilHealth member eh. Pag hindi ka nakabayad. But, being a direct contributor, may penalty ka. May penalty ka kasi hindi ka nagbayad. Hindi ka up to date. You will have to pay a surcharge. If you're an indirect contributor, walang such thing kasi wala ka namang payment eh. Wala ka namang due date na kailangan bayaran. So there's no such penalty.
Doc,
So
question
anong gusto
po,
nyo ngayon? Yes.
paano po yung mga voluntary member? Kasi since never po ako naka-experience mag-work, nagpe-pay po ako ng voluntary member na contribution for PhilHealth.
May capacity ka magbayad, therefore direct contributor ka.
Okay po.
Diba? Kasi you have a capacity to pay. Yun yung idea doon.
Doc, question
Oh,
ko.
EJ.
Kasi 2017 pa ako huling nagbayad ng PhilHealth kasi nagtrabaho pa ako.
Penalty ka na.
Penalty na yan.
Mag-update ka na bago ka magkasakit. Na wala namang
So,
issue yun kung kailan ka nagbayad or magre-resume ako ng bayad. Wala, itutuloy mo lang. Ang importante doon is paid ka at the time na magkasakit ka. Wala namang penalty. Ang problema dyan, kung at the time na nagkasakit ka, yung required number of months na bayad ka before ka nagkasakit, hindi ka bayad. Penalty ka. Bayad ka ng surcharge. Sisingilin sa iyo yun once nagbayad ka uli ng PhilHealth mo. Sisingilin sa iyo yun. Kasi direct contributor ka. So habang wala kang sakit, magbayad ka na. Yes.
Possible ba na hindi ako i-apply ko as indirect yun? Kasi hindi naman ako nagtatrabaho.
Hindi ka naman nagtatrabaho, so dapat beneficiary ka ng parents mo na nagwo-work. Beneficiary ka. Ang magde-default yung magulang mo kasi yung benefit mo will fall under their benefits. Pero 21 years old ka na, no? Hindi ka na considered as a dependent. Able-bodied ka eh. Di ba? Hindi ka na considered as dependent. Naku, wala kang coverage. Wala kang coverage. Eh, hindi ka naman pwedeng mag-declare as indigent kasi ang magulang mo may capacity mag-pay. Di ba? Ang magulang mo may capacity magbayad. Eh, paano ka makakonsider as indigent? Yung mga ganyan, very good questions. Kasi nga, paano nga yung ganun? You will only find out that mag-apply ka ng PhilHealth. Bumalik ka sa PhilHealth, tanungin mo. Di ba?
4,000 yung pinisingil sa akin ngayon.
Yun nga eh. Yun. And ganito. Right? Last year yun, Dr. Andres? Last year ba yun? Di ba yung nag-implement sila nung 2.5%?
Oo.
Last year? Hindi, the other year.
Last year pa.
Last year, the other year. Nagmadali ang mga healthcare providers. Bakit? Kasi if you're a healthcare provider, you're gonna be a doctor in the future. Pag nagbabayad ka ng PhilHealth mo, covered na ang iyong accreditation. Right, Dr. Andres? Tama?
Yes.
Covered na ang accreditation mo. Pag nagbabayad ka ng PhilHealth, covered na. Mag-a-apply ka na lang as PhilHealth healthcare provider. Kasi kailangan accredited ka para makakuha ka ng payment from PhilHealth. Right? Pero kung nagbabayad ka ng PhilHealth, bayad ka. Eh, ang daming doktor, hindi naman nagbabayad ng PhilHealth. And sabi nila, after December 7, iba na ang bayaran. It will be now based on your income. With a minimum, with a floor. Magkano ba ang floor? 20,000 ba?
Baba lang.
10,000.
Ha? Ilan?
10,000.
10,000.
Opo.
So if you make 10,000, doon ibabase ngayon yung bayad mo ng PhilHealth. Eh, kailangan bayad ka ng PhilHealth for pwede kang annual or 3 years ang bayad mo. So kung gusto mo magpa-accredited as annual, ita-times nila yon 12 para makakuha ka ng accreditation. Eh, if you're someone who's making 100,000 times 12, isang bayaran yon para makuha mo yung accreditation. So lahat sila nag-rush before December. Lahat mga nakaalam, December 7, nagbayaran sila habang hindi pa ini-implement yung bagong rate. And this rate increases by 0.5% every year from that start. So yung 2.5 dapat 3% na. Dinefer yata nila, di ba? Yung increase as of now because of the last year because of the pandemic. That's what I understand. Just imagine if you're making 100,000. Let's say 5% is the top is the maximum. Doon aabot yon every year up until 5%. Well, how much is 5% of 100,000? If you're making 100, decently making 100,000. How much is 5%?
5,000.
5,000 times 12.
60.
Times 3 years. Kasi 3 years ang accreditation.
180.
So you need to shell out 180,000 to get your accreditation kung hindi ka nagbabayad ng PhilHealth. And we had colleagues who had to pay 98,000. Pinakita nila yung resibo. 98,000. One payment para lang makuha nila yung accreditation. Why? Because you're not accredited, you won't get patients. Kasi PhilHealth ko ba kayo? Ay, wala akong PhilHealth. O, lipat ka doon sa doktor na may PhilHealth. Hindi ka magkakapasyente. That happened to me kasi hindi ako naka-update. Pero I was able to update before this transition. Na-delay ako ng update kasi the processing takes around ilang months ba? 3 months ang processing. So you have to update 3 months before your expiration. Eh, inabot ako ng expiration. So 3 months akong hindi makatanggap ng pasyente. Lahat nire-refer ko sa mga kilala. Even my own patients. Ang tinatanong ko, may PhilHealth ba yung pasyente? Wala daw. Sige, tatanggapin ko. Wala PhilHealth eh. Walang ina-expect na benefit. Okay? Okay. So, nandun na tayo sa sinusweldo nyo as kinikita nyo as a doktor. That payment covers for your indigents. Kaya nila kailangan taasan. Dahil sino ang magbabayad para doon sa mga indigent? Pondo ng gobyerno and also yung payment ninyo. Kaya nga ang clamor namin noon, bakit naman ganun? Ang laki-laki ng babayaran mo. Ikaw na nagre-render ng service, ikaw pa magbabayad para doon sa service na i-render mo doon sa pasyente na magbe-benefit doon sa binayad mo. Makita niyo yung ikot-ikot noon. Pasyente ko, walang pambayad. O sige, magre-render ako ng service sa kanya, pero yung i-render kong service sa kanya, ako rin magbabayad sa sarili ko. Parang pro bono na lang. Pwede wag mo na akong pagbayarin. Kaya nga sabi na, huwag mo na lang kami pagbayarin, magpa-pro bono na lang kami every time. Di ba? Wala pang samaan ng loob. Especially if you're someone who don't get sick. But the nice thing about this, if this is fully implemented, even outpatient services are covered. Yun. My brother benefited from this when he underwent radiotherapy, covered lahat ng PhilHealth. Because under the Z benefit package ng PhilHealth, usually 100% coverage of mga procedures. They put priority, that was implemented back when I was in public service, and that's a good thing. They put priority on the Z benefit package. Those are your terminal critical cases like cancer. Usually full coverage sila. And that's a nice thing. Okay? So, something to think about when you go for the interns, magbo-board exam na kayo, and then you have to think, what am I gonna do next? For the clerks, may 2 taon pa kayong mag-iisip, or a little less than 2 years para mag-isip, what career path am I going in, will I go into? Now, there are two things that we call the individual-based services. That's the one that we would render as primary care providers. And there are population-based services, and these are the ones that you will be rendering if you go into public health. So basically, they don't take away what we already have established in public health. No? Kaya sinasabi ko nga sa kanila, siguro they're just gonna implement it the way we implemented that at the health center. Kasi ganun kami sa health center. Walang bayad ng health center, right? Pero we report all of this sa PhilHealth, and PhilHealth pays us back. Sa PhilHealth kami nakakuha ng additional, other than our salary, nakakuha kami ng quote-unquote reimbursement for the services we render to our patients at the health center if the health center is PhilHealth accredited. And dinidivide dun accordingly. Me as the city health officer, matitira kasi doon 10%. 40% for drugs, 40% for technologies, including internet, pwede. Tapos the remaining 20%, 10% doon sa city health officer, me. 10%. So if it's 1 million, what's 10% of 1 million? 100,000. Tama ba? So I'll get 100,000 from PhilHealth. Kasi nagtatrabaho ko for that. Nung time ko, sabi ko, doon sa aking head nurse, si Ate Elsie. Ate Elsie, paano ba to? Kasi ang share natin is 120,000. That's the 20%. The 120,000 pala share ng CHO, ng City Health Officer. Yung 10%. The other 10%, 5% of that will be divided into our regular staff, and other 5% will be divided among those who actually help. So yung mga support staff, yung mga utility, mga janitor, pwede mong bigyan. Sabi ko, Ate Elsie, paano ba? 220,000 yung share ko. Sabi niya, Dok, ikaw naman nagtatrabaho, mga doktor mo hindi naman nagtatrabaho eh. So, sa'yo na lahat yan. Napaisip ako, baka naman sumama loob ng mga to. Sabi ko, sige, kunin ko na lang yung kalahati, divide natin sa kanila. But sabi nga ni Ate Elsie, Dok, wag na. Kasi entitled ka naman lahat dyan as City Health Officer. Sa'yo lahat talaga pupunta yan. Yung share nila, yung share ng 5%. Sabi ko, hindi na, wag na. Hatiin mo na lang. Sabi ko, basta may pang tuition lang ako ng anak ko, okay na. Pero pinirmahan ko yung buong amount. And then we divided it to the rest of the doctors. I don't know if that's how they do it now. So in public health, meron din namang gano'n. So they're extending it now, the same scheme, to to the private sector via your primary care provider. So yung pera in public health will go now to the local health board, to the city, that's a city, and it will be distributed to the staff. In the case of your universal health care, the payment will go to the hospital and they will divide it all the way down to the primary care provider. Kaya ang problema dyan, sabi nga ng iba, sino ba sa atin ang actually nagsusulat kung sino mga PhilHealth patient natin? Dr. Andres, ikaw ba nagsusulat ng PhilHealth to? Lista ko to, sisingilin ko to. Usually doctors are not into that eh. Basta pasyente, bayad and all of that. When this time, pag dumating, thank you, di ba? Thank you. Sabi nga ng isang pulmonologist na consultant namin, I like to call him boss namin, boss. No? Ninong siya nung anak ko. Sabi niya nga, we were driving, he was driving, I was with him, sumabay ako kasi he lives in Las Piñas as well. So pauwi kami. Sabi ko, Dok, ganda ng kotse mo. Sa new Honda City at that time. Dok, ganda ng Honda mo. Oh, alam ba pang bayad ko dito? PhilHealth. PhilHealth. Ganun kalaki yung PhilHealth niya dahil marami siyang pasyente. PhilHealth. Sabi ko, hindi ko na nga alam eh. Kasi wala naman sa atin nagmo-monitor. Magkano talaga PhilHealth mo? Basta dumating yung check-in, binabayad ko na. So, under primary care, if you're a primary care provider, you really have to keep your record. Kasi kailangan alam mo ganong karaming pasyente yung sisingilin mo dun sa Apex Hospital mo. Oh, I had 300 consults times this amount. Dapat ganito ibayad sa iyo ng hospital. Otherwise, gulo yan.
Ang problema dyan, sir, there are a lot of primary caregivers that would not be affiliated to a tertiary or even a secondary primary hospital.
If you're gonna be a primary care provider, required yun, kailangan affiliated ka in your referral network. Kaya nga, tanong ko si Dr. Crisostomo, are we pushing as an Apex hospital? Kasi para malaman, para ma-organize na sino yung mga clinics around the hospital which will be under our network. Kasi very tedious process yan. Magre-register pa yung mga primary care providers, especially if they're not affiliated with the hospital. Yung mga family doc na yan, kanino yan mag-affiliate? Di ba? Kaya those are the nitty-gritty that has to be really fleshed out. Okay? But there's another point pa, the local health board, because there's a provision on the universal health care that the money na ibabayad sa mga manggagaling sa PhilHealth has to go through the special health board. And that is headed by the mayor. So ang question nila doon,
sa pang-good luck,
special health board ang magde-determine ng distribution ng bayad. Paano kung suluhin ng LGU yung bayad? Sabihin walang dumating. Or sabihin, ganito ang distribution natin. Paano ang mga private institutions? They'll be at the mercy of the LGU. Kasi nandun ka doon ka nagpa-practice. So technically, you're really at the mercy of the LGU. Yun pa yung isang kino-contest nila. Because in the local health board, there has to be a representation from the private medical community, private health sector. So yun ang dapat na masigasig. Dahil kung tutulog-tulog yung representative ng private health sector, ay malamang baka hindi makakuha ng pondo. But then, if that happens, everything will collapse. Kasi pag hindi nabayaran ng mga facilities nyo, sinong magtutuloy niyan? Di ba? Sino magtutuloy niyan? So that's all of the issues there. But we're still looking forward to universal healthcare and all the benefits of universal healthcare. Wag lang ma-undermine yung importance ng health workers nyo, particularly the primary care provider and yung mga other people in the referral. Kaya again, yun ang concern ng specialists. Paano practice namin? Anong practice namin pag hindi kami ni-referral? Lahat ng pasyente kailangan dumaan sa primary care. That's why we need more primary care providers. 'Di ba? Yun ang goal. Kailangan marami talaga. Tadtarin mo ng primary care providers. Kung di man mag-refer sa iyo yung isang primary care provider, malamang isang primary care provider mag-refer sa iyo. That's actually my practice right now as a general internist. So I receive patients, basta adult patient, and then I direct them kung saan I would refer them. If oftentimes in my clinic, if it's just a consult, tapos they need another specialist, like surgeon po ang kailangan nyo, hindi na ako sumisingil. I don't even charge for the consult. But the patients come back. Kasi tapos, Doc, na-operahan na kami. Okay. For other concerns, they will come back to me. But in your universal health care, everyone has to pass through your primary care. If you watch you go on YouTube, see Z-Dog MD. Are you familiar with Z-Dog MD? Z-Dog MD. Gumagawa siya ng mga parody music videos. You search Z-Dog MD, he's a primary care physician. And he explains there anong role nila as a primary care physician. So technically, everyone passes through them. Kaya daming galit sa kanila na specialist. Yun ang lagi niyang himutok. Ba't galit sa amin ng mga specialist? Kasi one, if you're a competent, as Dr. Andres said, if you're a competent primary care provider, wala nang pupunta. Babawasan na mapupunta sa specialist. Another, patients cannot go directly to their specialist. They have to pass through you. Okay? So those are the things that you need to consider. Anything else? Any questions regarding the universal health care? Yun, yung funding, yun lang. You're, in essence, you are gonna pay. Ang sabi ko nga doon sa isang meeting namin with the Philhealth representative, hindi ba tax yan? Doc, hindi ho yan tax. Fee yan eh, fee. Hindi yan, tax yan. What's tax? It's a percentage of your income. Eh yun ang Philhealth eh. You're getting a percentage of your income. So tax yan. Ginagano ko kami. Tax yan. Tax. Pag hindi ka nakabayad ng tax, Philhealth tax mo, wala kang practice. Di ba? Tax yan. No, I apologize if I'm like this. I don't get in fights when we go into discussions. But ako kasi when there's a discussion going on, usually tahimik ako. Because what's going on in my mind is a way na para kontrahin yung discussion. Because the only way that you will learn and resolve something is if you look at all sides. Kaya ayoko nung mga meeting tayo tapos siya lang may karapatang magsalita. You don't have the right to give your that's useless. You don't resolve anything. You only follow what they want. Hindi na meeting 'yon. I-dictate mo na lang sa amin, di ba? So when you attend a town hall meeting, a consultative meeting, you're supposed to ask questions. And oftentimes I would ask the opposite of what's being proposed. Kasi I want to look at all possible scenarios. That's what kaya I actually made a YouTube channel. Pero hindi ko na natuloy. Facebook page. Pero ayoko, baka sabihin ko, sino to? It's called The 10th Man. If you watch World War Z, they have a 10th man policy there. So sa Israel, nakagawa sila ng protection against the zombies. Oh, spoiler alert. World War Z, they have a 10th man policy. What's a 10th man policy? Or 9th man. Depende kung gusto mo 9 or 10. Ang sabi nila, in a group of 10 people, if 9 people agree, the 10th man's responsibility is to always contradict the 9. Kasi if no one contradicts, you won't see the entire picture. And I think, and that's of course you have to do it, nicely, but that's a good policy to abide by. Pag nagmi-meeting kayo and you're exploring, dapat may isang naging kontrapelo. Kasi otherwise, you won't know. If everyone agrees all the time, you won't see the entire picture. That's why you are very encouraged to ask questions when we discuss in community medicine. Ano yung inyong perspective? Diba? Kaya pag nagtatanong kayo after reporting, doon tayo maraming napag-uusapan. Kasi you get to see your own perspective of the issue and not just what's being presented by us, by government. No, and that's a reflection of your critical thinking capacity. Okay, can we move forward? But everything else remains the same as presented, no? As presented. O yan na yung Philhealth. Kaya yung Philhealth yan, when I was listening to this Philhealth, actually that's from the Philhealth itself. And some of that has been changed because of the universal health care. Di ba? Napansin niyo. There are a lot of, some of that has been changed because of universal health. Your task now as future doctors is to familiarize yourselves with these changes, or what we call a paradigm shift. Familiarize yourself. It's a changing landscape, and by the time you get your licenses for the interns, as soon as you get your license this year, iba na. There are a lot of things that you have to learn. Kaya nga ang proposal ko sa principles of medical practice. Anong pinaiba ng principles of medical practice sa medical practice sa ano na PMP tsaka medprac? Ano yung difference ng PNP tsaka medprac? Di ba? Sabi ko nga ang proposal ko, dapat sa principles of medical practice, ang inaaral natin taxation, how to set up your clinic, di ba yung mga ganon? Di ba? How to set up a group practice. Sa medical practice, dun yung how to fill up a certificate. Kasi that's medical practice itself. Diba? Mga ganon, yung mga detail. So that when you go out and you have your license and you go out, alam nyo na, ito pala babayaran ko ng tax. Ganito pala mag-apply sa BIR. Okay, but this has to be updated kasi BIR, daming bago-bago lagi sa kanya. Every time. Ito pala kailangan apply ko sa Philhealth. Hindi tayo, So when you get your license, don't hesitate to ask your seniors. Ako, in our society, if I find out something, I share, even paano mag-compute ng tax, sige, I welcome those questions. Dok, ano ba babayaran ko this, sa Las Piñas Medical nga, ako yung nagpo-post ng, bayaran na ng ganito, bayaran na ng gano'n, baka nakakaligtaan. Wala kasi akong accountant. Sila meron. Hindi nila iniintindi yun. Ako wala. Ano naman, I do everything myself. I have to pay my BIR this week. Deadline na. Ako nakabayad ng annual fee. Yun yung gagawin ko tomorrow and until Friday. Kaya sabi ko, Dr. Andres, di po available ng Thursday and Friday. Pag natapos ko bukas, pwede na.
Annual na ba? Di ba fourth quarter pa lang?
Hindi po, yung annual fee. Yung 500 pesos.
Yung 0606. 0605.
Alam niyo ba yun?
Nasingil na ako eh. Di alam ko na.
Yung interns, alam niyo ba yun? May babayaran kayong gano'n.
Taon-taon
those are the
naman.
things that you have to familiarize yourself with.
Binabasa ko naman yung bill no accountant. Kaya paano?
Wala, honestly, kasi wala akong pondo pang bayad sa accountant.
Well, gusto ko ding alamin for myself kasi minsan.
Well, that's my principle. I want to know it myself. Para kung kumuha ako ng accountant, alam ko hindi ako niloloko ng accountant. I had I had a colleague, nagkasabay kami sa bangko. Nagkukwento siya. Niloko siya ng accountant.
Ako, it has happened
Laki
to
ng
us.
babayaran niyang penalty. All the while, alam niya, inaasikaso ng accountant niya, hindi pala, bayad siya ng bayad sa accountant. Diba? Kaya ingatan niyo rin. Alright? Okay? So, pag residency kayo, kailangan nagbabayad na kayo ng tax, ha? Kasi considered ng salary yun. Yun pa isa. Alright? So, anything else? Any questions before we part? Thank you, Monina, for joining us remotely. It's 1 o'clock already. Okay, I hope you learned something. Yes. Yes po.
Wala na.
Okay na. So, exciting days ahead and years ahead, especially for, new doctors because of the new landscape in healthcare. Sana maka-adjust tayong lahat. All right? Any last words from anyone? Works, interns? No, looking forward ba? Are you excited to practice already?
Bigla naisip, bakit ba ako nag-doktor pa?
Okay. New guidelines were released by for the interns. I posted it on our Viber group. New guidelines released by APMC yesterday on regarding face-to-face. So anytime that the institution deems it to resume, pwede na. Yun ang pagkakasabi.
Lahat sa Dr. Crisostomo mag face-to-face, di ba?
September pa. Ano rin, doon na rin nakalagay na kailangan minimum 6 months if possible. So I think we'll really push through with O yung gusto ni EJ, excited na yun. No? So get your stuff ready. I'm asking Dr. Crisostomo for details so I can communicate it with you guys already. I'm coordinating with the coordinators for the interns for the departments, and we'll be having an orientation of the interns. Yung pati kayo, yung mga interns as well, current interns. I think you are asked to join. No, I think you are asked to join. Oh, sorry, may tumatawag na kasi may meeting din ako. Mamaya na. All right.
Excuse po, Doc.
Yes.
Supposedly po meron pa pong report po yung PGIs po. Kailan na lang po?
On what? On ano yung sabi ko?
DOH.
Framework
Programs.
po, Doc.
Framework. Sa Thursday na lang. Sa
Sabay
Thursday.
natin sa community server.
Thursday. Thursday. Okay.
All right.
Thursday ba? Let's confirm.
Thursday.
Thursday. Okay.
Hindi ka pwede? Pwede naman ako. Pwede naman ako sa Thursday.
I'll see
Okay.
if I can
Sir,
change my schedule.
Sir, may question sa COS mo. Kasi 20 hours yung nilagay. Tapos, di ba 2 hours per week lang? Sinabi ko naman, alam naman natin na 2 hours per week.
Pero you have to
kasi,
put what's actual.
oo. Pero sa records kasi namin, naka 20 hours umabot that
Kasi
month.
5 weeks.
5 weeks times 10. Yun nga. Yun lang. Sabi ko, pero alam naman namin na 2 hours per week lang ang maximum.
Baka nagtataka tong mga to.
Sorry for you to hear that.
Hindi, baka nagtataka tong mga to. We're talking about payment especially this is for the international. Kasi di ba, we conduct online sessions when technically dapat hindi. So anyway, kung sa trabaho namin for 1 month, ang babayaran lang nila is 2 hours, regardless of how much work we do.
2 hours per week naman, sir.
Per week, 4 hours tayo, di ba? So, anyway, not to, put the pero that's the effect of the pandemic. Naintindihan naman namin yun. Naintindihan naman ng faculty. And this is commitment naman, more of commitment rather than anything.
Hindi naman pwedeng 2 hours tapos biglang i-end natin yung Zoom call kasi
2 hours
yun lang ang bayad. 2 hours tapos na. Alright.
Okay.
So,
Walang ganun with us.
Walang ganon.
Clarify ko lang po ulit.
Yes,
Yung sa
Abby.
Thursday po, bali po kasi may reports po ulit yung PGI and clerk. So kami po yung community diagnosis, tapos COVID po yung kanila. So magiging dalawa po yung reports po ng PGI sa Thursday. Okay po, Doc.
Sige.
Sige. Hanggang kailan kayo, clerks?
Hanggang Tuesday sila.
Hanggang
next week.
Tuesday. Naku, kailangan na natin magpa-exam. Tuesday, paano pang nag-face-to-face? Ay, hindi. Nakalagay naman community, pwedeng virtual pa rin.
Ang itsura ni EJ Next time?
Ang interns, hanggang kailan? End of the month na ba kayo?
Doc, end of January po.
End of January, di ba? Alright.
So hanggang Thursday na lang sila.
Friday.
Friday.
Hindi, Sunday. Meeting tayo sa Sunday. Meeting tayo sa Sunday para sulit. Lubos-lubos. Hindi. Alright. Sige, we'll see you on Thursday. Thank you very much.
Thank you for attending this session. See you Thursday. Alright?
Okay.